Can I start now, Miss Shams? Thank you. Okay. So this is our heart, and this is the right atrium, and this is the right atrium, and this is the right ventricle, and this is the left atrium, and this is the left ventricle. So what normally happens? The right atrium receives the oxygen-poor blood, or the blood that carries CO2, from the body through the superior vena cava and inferior vena cava. Okay, then the right atrium will pump the blood to the right ventricle here. So the right ventricle would like to get rid of the CO2 and get O2. So it will pump the blood through the pulmonary artery to the lung, and the exchange of O2 and CO2 will happen in the lung. Now in the lung, the blood become oxygenated, become good. So the left atrium, this one, will receive the oxygenated blood from the lung through the pulmonary vein. Then the left atrium will pump the oxygenated blood to the left ventricle. The left ventricle now would like to deliver the oxygenated blood to the rest of the body. So it will pump the blood through the aorta to reach the reach of the body. We will notice here that the pulmonary artery is the only artery in the body that carry non-oxygenated blood. On the other hand, the pulmonary vein is the only vein in the body that carry oxygenated blood, because generally speaking, arteries in our body carry the oxygenated blood and vein carry the non-oxygenated blood. Only the pulmonary artery and the pulmonary vein are the exception of this rule. So this what normally happens in our body. Okay. Okay. Now, before we talk about that, I need to say that when we define heart failure, what is the meaning of heart failure? Heart failure is two types. One is systolic and one is diastolic. Systolic heart failure and diastolic heart failure. The systolic heart failure means that the heart cannot pump hard enough. Like the ventricle, this one, that pumps the oxygenated blood to the rest of the body, does not pump hard enough. Okay? Diastolic means that the heart cannot fill enough, which is this one. This one that receives the blood from the body cannot fill enough. So if it cannot fill enough, this is diastolic, and this is what we don't focus on mostly here. But what we focus on more is the systolic one, the one with the issue with the left ventricle here. Okay, so what will happen if the heart cannot pump hard enough? There will be a remaining amount of the blood in the heart. And also, if the heart cannot fill enough, like here, means that the blood that was coming from the rest of the body will accumulate, because not all the amounts can be received in the heart, leading to accumulation. So we might have accumulation here in the left ventricle, or we might have accumulation in the rest of the body, or even accumulation in the lung. All these types of accumulation will lead to congestion. This is why it's called congestive heart failure. Congestive due to the congestion of fluids, either in the heart or in the lung or in the body. Heart failure because the heart failed to pump enough amount of blood, and this is the systolic, or because the heart failed to be filled enough with the blood, and this is a diastolic heart failure. Okay, So if we talk about the important one, which is the systolic heart failure, which we say the heart cannot pump hard enough. First, we need to know something, cardiac output. Cardiac output is the volume of the blood ejected per minute. How much blood the heart will eject per minute. This is the cardiac output. And the cardiac output, to calculate it, we need to know how many beats per minute the heart can make multiplied by the volume of blood that each beat ejects. Normally, in a normal person, a heart will beat around 70 times per minute. And each beat will pump 70 ml per beat. So to calculate the cardiac output per minute, I will multiply 70 by 70, which equals to 4,900 ml per minute, which is almost 5 liters. So this is what is pumped per minute by the heart in a normal person. Okay. So where the problem is, let's take this slide first. So generally, your ventricle here, the total volume is around 110 ml. Okay, and when your heart beat, each beat can eject around 70 ml, which means that there is a remaining quantity of the heart here in the left ventricle after each beat, which is totally fine because the next beat will pump this amount. So a normal person, each heartbeat will give 70 ml, and the total amount is 110 ml in the left ventricle. So if I'd like to calculate the ejection fraction, I will divide 70 by 110. It will give us around 64. And 64 is considered a normal value. So the heart is doing well if I can achieve 64. Normally, I can say that a normal ejection fraction of 50 to 70 is fine. That's totally fine. Okay? Between 40 and 50 is a borderline. Less than 40, this is the diagnosis of systolic heart failure. So, me as a person, my ejection fraction is 62. So I'm okay. Someone is 45. He is borderline. I need to monitor him. Less than 40, he is diagnosed already with systolic heart failure. So this percent will change according to what? According to the amount of blood that each beat can give. Like for example, if someone beat can give 50 ml. So what will be his ejection fraction? I will divide 50 by 110. And depending on the numbers that will come, I will look to this scale and see if it's less than 40%, it's a systolic heart failure. If it's here between 40 and 50, he is borderline. And so this is the way how I can calculate the ejection fraction. Okay, so this is regarding the systolic. But what about the diastolic heart failure, which is this one? In the diastolic heart failure, we said that Amr is saying isn't 40 to 50 still considered the heart failure? Yeah, it's the heart failure with preserved ejection fraction, but because we treat it in a different way, because we treat it in a different way compared to the systolic one with reduced ejection fraction, we don't mention it that much. Anyway, as you open that topic, regarding the heart failure with preserved ejection fraction, we don't treat the disease itself. We treat the risk factors that lead to it. Like if someone has high blood pressure uncontrolled, we control it first. If the reason was diabetes, we control the diabetes first. So we don't treat the thing itself. It's mostly about treating the triggers or the risk factors for that. Okay, where we were. Okay. So if someone has a stroke volume, which is the volume of blood per beat is 44. If I divide 44 by 110, it will be 40%. So this is systolic heart failure. In diastolic, which is this one, I will find that the ejection fraction is still high, like 64, which is normal. So it's weird, like how the ejection fraction is okay. However, the patient is diagnosed with diastolic heart failure. Can someone answer this question here from the graph or from the image? If someone can deduce the answer. Why in the diastolic heart failure, although the ejection fraction is still normal, the patient is still diagnosed with diastolic? How this happens?
It's because the total volume is low. The heart cannot fill enough.
Thank you so much. Yes. So because in the diastolic, we said that the problem is in filling. So the amount of the blood in the ventricle here will not be 110. No, it will be less because the heart cannot fill enough with blood. So let's say, for example, the amount in the ventricle here is 69 ml. So even if the stroke volume, which is the volume each beat give, is still low, which is 44, if I divide the 44 by 69, it will give me 64, which appears to be normal. But the problem is not now in the value of the ejection fraction, it's about the volume in the left ventricle, which is 69, which is totally less than the normal, which is 110. This is why it's called diastolic. Diastolic when the heart relaxes, when the heart receives a blood. So the amount received is less than normal. So it's diastolic. Okay. This is the pathophysiology. Why we develop heart failure, why someone will be diagnosed with heart failure. So there are many mechanisms behind the development of heart failure, and it's a kind of reaction by the body to the change. So first, if I, as a normal person, my body start to has more CO in the blood, what will be the reaction of my heart or my body to get rid of this CO? Either my body will start to give more heart rate to the heart, so the heart is pushing more, delivering more blood to the lung to exchange CO with O2. Okay? Or my heart might enlarge the ventricle wall. I need the ventricle to be stronger, to push more blood out. So this kind of enlargement of the ventricle wall is called hypertrophy. So it's hypertrophy of the ventricle wall. What else? My body might stimulate the RAS system, the renin-angiotensin-aldosterone system. So by stimulating the RAS system, I'm causing a kind of vasoconstriction. This vasoconstriction will make my vessels constricted more, and by that, I'm pushing more blood. I'm returning more blood to the heart, and I'm pushing more blood by the heart to reach to the lung to get rid of the excess carbon dioxide or carbon monoxide, depending on what my blood carry. So these kind of changes that happen will lead to deterioration of the heart function, hypertrophy of the ventricle wall, heart racing, and many issues that need to be treated. So the triggers of the heart failures, some disease like hypertension, ischemia, arrhythmia, all of these, like there is something abnormal happening in the heart, leading to accumulation of fluid and blood in the heart. Also, some drugs might cause that, something like NSAIDs, that will affect the constriction of blood vessels, that will affect the thinning of blood. Also, TCA, tricyclic antidepressant, yeah, yes. Also calcium channel blocker and beta blocker itself, because they weaken the contractility of the heart. And by weakening the contractility of the heart, it means that more fluid will be kept inside the heart. Some medications like clozapine or chemotherapy are considered cardiotoxic. Cocaine and some of the illegal drugs are cardiotoxic too. So these are some of the things that might lead to congestive heart failure. This is a so complicated picture to make a connection between the diabetes and heart failure. Anyway, what I need to tell here, diabetes is a risk factor for heart failure. Okay, regardless of all these details, we don't need that. So diabetes, like hypertension, or like hyperlipidemia too, are risk factors for heart failure. And we already said briefly that for a high cholesterol and high blood glucose, the function of the blood vessels will be affected due to the accumulation of either glucose or cholesterol in the internal wall of the vessel. And so the blood supply will be affected, and we can deduce how the issue will happen in the heart based on that. Okay, these are the things we were talking about. Okay, so this is a scale we were talking about. So when the blood pressure is high, the peripheral resistance is high, and because the resistance of the blood vessels is high, the ventricles start to develop hypertrophy and remodeling to be able to overcome this resistance, to be able to pump the blood out of the heart. And this kind of high resistance will lead to less ejection of blood, and will lead to, because the amount of blood coming outside the heart is low, the amount of blood reaching the kidney will be low. So the kidney will respond by activating the RAS system. The kidney feels that the blood is not enough. So the renin-angiotensin-aldosterone system is activated to constrict the blood vessels to achieve more blood flow to the kidney. This kind of RAS activation will lead to sodium and water retention due to the aldosterone. And all of these reasons together will lead to congestion of blood and the fluids in the body. This is like why I use ACE inhibitor in congestive heart failure. We will go through that, but just this is a brief thing. So ACE inhibitor will decrease the peripheral resistance. ACE inhibitor and MRA will work on decreasing hypertrophy and remodeling of heart cell. Digoxin will help in increasing the ejection of blood, because digoxin has a positive inotropic effect, which is increasing the contractility of heart muscle. Repeat again, please. Repeat what? Sorry. What do you want me to repeat?
Okay. The mechanism between the high blood pressure and how it is get a heart failure, because I know by heart it is the main risk factor of the left ventricular hypertrophy is the hypertension. Okay, but I cannot connect between both. How the hypertension leads to left ventricular hypertrophy.
Okay. So when someone have a high blood pressure, it means that his peripheral resistance is high, like there is a constriction of his blood vessels. Okay. This kind of constriction of blood vessels, what it will lead to? The left ventricle pumps the heart, pumps the blood through the aorta, and the aorta will deliver the blood to the arteries. So these arteries are already constricted. So the aorta cannot pump the blood through these vessels. So what will happen? The ventricle will try to contract more, to push more blood, so it can be delivered to these constricted arteries. So this level of high contractility to be achieved, the ventricle start to develop hypertrophy, to make more cells, to be more stronger, to be able to push more blood to overcome the resistance by the peripheral vessels. You got it or not?
Yes, sir. Thank you.
Okay, so we went through that. Okay. Okay, so we have like left and right ventricular hypertrophy or ventricular congestive heart failure. So the low ejection on the left, which is the systolic one, which is associated with contraction, when it's low, it will lead to accumulation of blood in the heart, which means increase in preload. Preload is the volume of blood received by the heart or in the heart. Preload, the volume of the blood in the heart. And it depends on the stretching ability of the heart muscle. This is the preload. Okay, if the preload is high in the heart, what will happen? Now, the blood that is coming from the pulmonary artery to the heart cannot enter the heart because the heart is already full with blood. So this blood will return back to the pulmonary. Okay, and this will lead to congestion of lung. On the other hand, the oxygenated blood that is coming to the heart by the pulmonary vein, it cannot enter the blood because the blood is already full or already has a high amount of blood. So what will happen? The blood coming through the pulmonary artery or the pulmonary vein will be ejected back to the lung because it cannot enter the heart. This will lead to congestion of lung. Lung will have more fluids now. So what will happen? Your lung is the space where like the CO2 can go away and we can get O2. Now it's full of fluids. This process will be affected. So what will happen? You will be having dyspnea like that because the process is affected now by the amount of fluid in your lung. So your lung cannot be functioning very well now. So to overcome that, your body is trying to take more oxygen. This is the reason for dyspnea. You need more oxygen, and your body or your lung cannot get rid of the CO2 and give O2 to the blood due to the accumulation of fluid. You have more dyspnea, like that. Okay. So this process is disturbed now. The normal process in your body is disturbed now. Okay, now I have blood accumulated in the heart, and I already have hypertrophy in the left ventricle and the right ventricle. The right ventricle, I need someone to open the mic, please. I need someone to keep the conversation with me. Would like
Yes, doctor. Yes, doctor.
Okay. I'm sorry, who is talking?
Ahmed.
Ahmed, okay, Ahmed. So based on that, on the congestion of lung and the dyspnea that is happening now, we said that your left ventricle already developed a problem and hypertrophy. What will happen to right ventricle too? What was the rule of right ventricle first? What right ventricle does?
It collects the blood from the whole body. The ventricle is pushing the blood to the lung.
Exactly, to get rid of the CO2.
Yes.
Okay, so now your lung is full of fluids and the blood. What does this mean to the right ventricle?
It will push more to the lung. It cannot push because already the lung is full with blood. So
yeah,
it will accumulate. It will over pressure on the lung, and even though it will not push, it will stay the blood in the heart, in the left ventricle. In the
right ventricle.
Yes.
So what will the right ventricle does to have more power? We need more power now to push the blood to the lung.
the lung, the walls will be thickening to having the lung will be enlarged because of accumulation of blood, and they will try to push more and thickening of the walls in order to try to push the blood more.
Exactly. So hypertrophy will happen to the right ventricle too, correct?
Yes.
So the problem starts by hypertrophy in the left ventricle, and due to the accumulation of fluids in the lung, the right ventricle cannot push more blood, so a hypertrophy happens to the right ventricle to have more power to push blood, correct?
Yes.
So what is now congested? What in your body is now congested with fluids?
The lung
And what?
And the heart.
Exactly. Now your heart is congested with fluids, and the vena cava, the inferior and superior vena cava, would like to deliver the non-oxygenated blood to the heart, correct?
Yes.
Will these fluids be delivered in a right way to the heart, which is already congested?
No, it will.
So what will happen based on that?
It will be. It will make an accumulation of fluid within the body.
Within the whole body.
Body, yes.
So now what I have a congestion in lung, a congestion in heart, a congestion in the whole body. So now you know how the congestion happens.
Yes.
Okay. And this is why diuretics is a main therapy for heart failure, because I need to get rid of all the congestions that happen. Anyone has a problem now with understanding how the congestion happens first here, then there, and why the hypertrophy happen in the left ventricle and then transfer to the right ventricle? Does anyone have a question or anything unclear as of now before we go further?
Doctor, I have a question. For the from the the hypertension lead to systolic or diastolic heart failure or both?
If someone has a high blood pressure?
The hypertension patient.
Yeah.
We know that the hypertension patient leads to left ventricular hypertrophy. Okay, it is the main reason. Okay. Now, this patient with have left ventricular hypertrophy leads to systolic or diastolic or both heart failure.
So, generally speaking, systolic is more common, okay?
Okay, systolic heart failure, which is pumping the blood to the whole body, from the heart to the whole body.
Yeah, but we said with the systolic, like the graph I was talking right now with Ahmed, with the systolic, the hypertrophy will happen to the left ventricle, and then it will be transferred to the right ventricle, correct?
Okay.
So the right ventricle is the ventricle that receives the blood. The blood is received first to the right atrium, then it goes to the right ventricle. So if a hypertrophy already happens to the right ventricle, it will not be able to be filled fully. And when it's not be able to be filled fully, what case will develop here?
Systolic hyper.
No. If the problem with the filling, what will be the case here?
The problem with the filling is diastolic heart failure.
So they are connected. Don't try to separate them from each other. So high blood pressure, hypertension will give systolic first, but systolic anyway will give diastolic. So it's connected. So don't try to say high blood pressure will only give systolic. Systolic itself will give diastolic, okay? Or the right ventricle will give the left ventricle hypertrophy will give right ventricle hypertrophy. So they are connected together. Okay. Anyone has any question about like the introduction. This is the introduction, by the way. We didn't start yet. So anyone has anything unclear about what we said? If it's clear, please say it's clear so we can go. Like, give me a hint so I can move forward. Or so it's clear, correct? Okay, thank you. Yeah, please react with me. I need reaction. Reaction makes me go. Okay, so now this we already talked about that, the kind of drug that might cause the congestive heart failure. Now, what should I do to treat the congestive heart failure based on these givens? I need to improve the cardiac output. I need to increase the pumping. And I need also to decrease the workload by the heart. How can we achieve that? First, I can do some non-pharmacological therapy. First, I will decrease the fluid. The body, the heart, the lung are already congested. So I need to limit the fluid I'm taking from outside. My body is already congested, so I need to limit that. Also, I need to limit the sodium intake. Smoking is cessation of course, because the blood vessels are already affected. And smoking will harm the blood vessels more. Yeah, I'm speaking. You don't hear me? Yes, I'm speaking. What's happening? Okay. We hear you. Okay, so NYHA, I think NYHA Vancouver is okay.
Okay, it's okay now, doctor. Thank you.
My pleasure. Physically active, but not physically overactive, because overactivity means more oxygen need, and your heart already has a problem. So stay active, but not overactive. Vaccinations are important because if you have a problem with your blood circulation, it means that your immunity will be less. So you need to update your vaccination and take all your vaccines. Also, you need to monitor your weight, because if you find yourself increasing in weight on a daily basis, it means more accumulation of fluids. So you need to keep an eye on that. Okay. The New York Heart Association classified the heart failure to 4 stages: class 1, class 2, class 3, and class 4. In class 1, there is no symptoms with ordinary exercise or ordinary activity. Like if someone can walk for 200 meters without an issue, this is a class 1. In class 2, you will start to develop symptoms of dyspnea, shortness of breath, difficulty breathing, feeling congestion in your chest. This will happen with ordinary activity, with walking for like 200 meters. In class 3, the symptoms occur with less than ordinary activity. Like when someone starts to walk even for 30, 40 meters, the symptoms develop. So this is class 3. In class 4, symptoms occur at rest. Even when you are sitting, you have symptoms. So this is class 4. So the NYHA, New York Heart Association classification is the most commonly used classification of heart failure stages. Okay, before going to the medication, there are some devices, but it's not our job to go deeper in that will help in increasing the cardiac output. A pacemaker to regulate the heart rate and achieve balance between heart rate and the contractility force, or ventricular assist device, something to help the ventricle to contract more and push more blood, And these are usually used in NYHA class 2 to 4. Regarding the pharmacological therapy, Champs, can you stop recording for for a second? Please, okay. Please don't tell anyone about what just happened, okay? Anyway, regarding the pharmacological therapy, if we remember what happens in our body, like the remodeling of heart cells and blood vessels, and also the accumulation of fluids, the simple idea is that I need to give something to get rid of the extra fluid in my body. I also need something to restore the normal functioning of cells. So to get rid of the fluids, what I'm going to give? Please write to me or respond to me.
Niloxamide.
Diuretics.
In general.
Yeah, so I will give diuretics. Okay. Regarding the restoring of the function of cells, what I will give? What is the family that protects the cell, protects the vessels?
ACE.
Good. Also, I need to decrease the effort done by the heart. The heart is already, the heart already has a problem. I need to decrease the effort done by the heart. So I'm going to give what?
Beta blocker.
Exactly. So this is how we simply deal with heart failure. So generally what happens, the doctor will give a low dose of ACE inhibitor plus beta blocker, and then we titrate it up according to the patient condition. So the first question is, why don't we give the ACE inhibitor and the beta blocker on the highest dose from the beginning? Why? I need an answer. Why I start low and go up slow by ACE inhibitor and beta blocker? Any idea? Any thoughts?
To avoid reflex tachycardia or heart block, maybe. I believe that ACE inhibitors will cause rapid hypotension leading to reflex tachycardia, maybe, which will increase the heart.
Exactly. So is the heart of a heart failure patient ready to go through tachycardia?
No, I guess not.
Okay. And regarding the beta blocker, why I start low on beta blocker?
Because they may cause heart block.
No, alone, like beta blocker alone will not directly cause heart block. But what's happening in a congestive heart failure patient? Is he in a case of decompensation already or not? Like the amount of blood delivered to the organs is already reduced or not?
I guess it depends on the stage of the disease. If it's in a late stage, yes, it will be.
Okay. So generally, as a patient is diagnosed with congestive heart failure, the amount of oxygen and blood delivered to the rest of the body is less, generally. If I give him a beta blocker in a high dose, means that I'm giving him a kind of bradycardia, so the amount of blood ejected by the heart will be more or less. And this is of course unfavorable situation. I still need to achieve enough blood supply and oxygen to the organs, so I need to start low and go up slow. Okay. Why ACE in low dose? Because of the risk of hypotension that will happen if I give him ACE inhibitor in a high dose. It will cause a severe reduction in blood pressure, and so the body will react by increasing the heart rate, causing a tachycardia. And having a tachycardia in a patient who already has congestive heart failure is very dangerous, correct?
Okay, correct.
Okay.
But I have another question, please. When I study heart failure, I am think about something. This heart, it is a lazy heart, cannot. So it is systolic or diastolic heart failure, problem in pumping and the problem in filling. When I give him a beta blocker, when I give him a beta blocker in general, the beta blocker have a negative inotropic and a negative chronotropic effect. So from my mind, I worsen the case, not improve the case. So why giving beta blocker in such this situation? This is what make me confused in treating heart failure in general with a beta blocker special.
Okay. Anyone has any response for this question? It's a good question, Armia. Anyone has a response, has a thought for that?
Well, I need to hear the question again, please.
He is saying that what he meant by his question, or what he thinks, is that a congestive heart failure is already a lazy heart. So if I'm giving a beta blocker has negative inotropic effect, like it decreases the contractility of the heart, in addition to the negative chronotropic effect, which is the heart rate. So I'm making it more lazy heart.
Okay.
Which
well,
will.
Okay.
Yeah.
I think I get it now. I think the point is that it depends on what you're targeting, what you want to do. And we're not targeting restoring the heart to its normal function. We're actually preventing further deterioration. So you're preventing further cardiac changes that will lead finally to a complete failure of that heart or a complete failure of it to do its function, but you're not trying to restore it to the 100%.
Yeah. Okay. Yes. Yeah. Thank you. So when I use beta blocker in heart failure, I use it for a main reason, which is decreasing the mortality. Because the clinical trials prove that specific beta blocker will decrease the mortality rate in patient who has heart failure. This is why I'm using specific members of this family. I don't use atenolol, for example. I don't use propranolol. I only use bisoprolol, or I use metoprolol succinate or carvedilol. These three members only show a benefit in decreasing mortality in congestive heart failure with reduced ejection fraction. And as we are talking about them now, I need to mention something. In Canada, we don't have metoprolol succinate. We only have metoprolol tartrate, and the tartrate salt is not effective in decreasing the mortality in heart failure. So the only two used in heart failure patient in Canada are bisoprolol and carvedilol. This is first. Second, defining the congestive heart failure is lazy is not correct. It's not lazy. It's trying to be active. It's trying to overcome the resistance of the blood vessels. It's trying by making more cells in the ventricle. This is why hypertrophy happens. So these trials done by the heart might make the heart like beat more per minute to pump more blood. So I need to control that. It's not a lazy heart. It's a heart trying to be active, trying to overcome the circumstances around it. It's like, see it this way. If you are a good person, Armia, if you are a person, but you have hard circumstances around you in your life, you have family issues, you have financial issues, what will you do?
I compete with this. Okay, yes, sir. I am with you. I compete with these issues. So it is a hard times. I know your point of view. That is the hard to try to compete. Is the congestion happen or the peripheral resistance happen in the peripheral vessels inside and outside. So I have to let him slow down a little bit. Is this
Yeah,
your point of view?
like a friend is coming to put his hand on your shoulder saying, Armia, relax. It's not your fault. You know, you are trying to be active, doing more things and move around to solve the situation. So the beta blocker is just a friend coming to put his hand on your shoulder saying, relax, it's not your mistake. However, he is not telling you you have to relax right now. This is why we don't use the high dose of beta blocker. It just, I start with low dose. I'm just telling you, keep going, but relax. Don't overpress yourself. You know what I mean now?
Yes, okay. Yeah.
Okay. However, if a patient is acutely decompensated, I don't give him beta blocker. If he is acutely decompensated, like there is a problem with the blood reaching the kidney, I don't give beta blocker in this case. So we don't give beta blocker in acutely decompensated heart failure patient. However, once the situation is improved and we can restore the blood circulation to almost a normal situation, we can start using beta blocker at that point. Anyway, I gave the patient ACE inhibitor and beta blocker, and then I titrated up, but still the symptoms are there, and the left ventricular ejection fraction is still 40 or less. Now I will add the MRA. Okay. Anyone can help me what MRA means? And an example for that?
Mineralocorticoid receptor inhibitor.
Inhibitor or agonist?
Agonist.
Okay, and what are the examples of that?
Spironolactone is example.
Spironolactone and what, sorry?
Just spironolactone, as I remember, eplerenone.
Okay. What is the most common side effect associated with the spironolactone?
Hyperkalemia and gynecomastia.
Yes. Due to the anti-androgenic effect of spironolactone, it might cause gynecomastia and reduced sexual function. This is why if gynecomastia occurs with a patient, we convert them to eplerenone. Okay? Eplerenone doesn't cause this side effects. I'm sorry, Shams. What no BB? On your comment, you said no BB and crying, then yes BB and said, what's happening? I'm sorry, I'm confused.
I'm sorry.
Oh, you were already crying? No BB
No.
and
Because you're saying it's like a friend. So I just imagined it decompensated because he has a lot of fluids. So crying, he's flooding with his tears. So there's no BB. But when he's a better state, no crying. Okay, BB can be used. Just
and we were supposed to understand that, correct?
yeah. Sorry,
Okay.
my fault.
Okay. Okay, so we will add the diuretic, the MRA, to decrease the fluid retention. Okay, at that point, if the symptom's still there, I need to realize that what I'm giving is not enough. I need to change. So I will change the patient from the ACE I'm giving to the ARNI or ARNI for in a brief, and we will talk about that. But if the symptoms are okay, like after adding either in the first step of ACE and beta blocker and he is okay, I just keep monitoring the patient and adjust the doses based on that. Or even after the second step, after I added the MRA, the spironolactone.
Sorry.
No worries. After because I didn't know what happened. After I added the spironolactone, if the symptoms are controlled, I need to monitor the patient now and adjust the therapy. So generally what happens, you will find that most patients are on the three together. It's rare to find a patient on ACE inhibitor and the beta blocker only. You will find that they are on the three together. This is what generally happens with heart failure patients. Okay, now after the triple therapy, if the patient is not okay, the ejection fraction is still less than 40 and the patient is showing symptoms. Now, I need to use a combination between angiotensin receptor antagonist and something else called sacubitril. Okay, this combination was found to achieve better outcome for the patient who didn't improve on ACE inhibitor alone. So I changed the ACE inhibitor to the ARNI, the combination between valsartan and sacubitril. And this combination was found that the sacubitril part increased the bioavailability or the efficacy of valsartan. So we are now achieving more control in remodeling and the hypertrophy that happened to the congestive heart failure patients. Okay. This combination was found to reduce mortality and hospitalization, but I need to keep in mind that I shouldn't use it if the potassium level is more than 5.2 millimole per liter, or if the glomerular filtration rate is less than 30 mil per minute. Okay. If someone is using ACE inhibitor, like enalapril, for example, and I'm going to convert him to the combination between the valsartan and sacubitril, when will I give him the dose of the combination? What is the washout period?
36 hours.
Okay, 36 hours. So someone who used to take enalapril every day at 8 a.m. and the doctor is changing him to the combination, when he will take the combination?
Again, please, your question was something in the
A patient has been taking enalapril, a congestive heart failure patient has been taking enalapril every day at 8 a.m. and the doctor decided to change him to the combination therapy. So when he will take the new medication?
He can stop the other day and start the morning or afternoon of the second day.
If he take it the morning, now it's 24 hours.
Yeah, he started, if he take today morning, so he gonna take it Sunday afternoon.
No, so I think Hind replied correctly saying 8 p.m. because at 8 p.m. of the next day, it's almost 36 hours, okay? So I need to be accurate about it. Like not just afternoon, at 8 p.m. after 36 hours. Okay, what if the patient wasn't taking ACE inhibitor? He was taking telmisartan, for example. He was taking telmisartan and bisoprolol and spironolactone. And the doctor would like to change him to the combination therapy to stop the telmisartan and start the combination therapy of sacubitril and valsartan, when he should take it. And he was taking the telmisartan at 8 a.m. every day. Okay. Yes, exactly. So they say that the washout period is 24 hours. So what 24 hours mean? I will take it on the same time the next day, because if he takes the telmisartan, for example, today, Friday at 8 a.m., Saturday 8 a.m. is already 24 hours done. So I can give him the combination tomorrow at 8 a.m. So I can say that I wait 24 hours after ARB, after angiotensin receptor antagonist, and I wait 36 hours after ACE inhibitor. Yeah, I will take it almost the same time the next dose. Is this point clear?
No, for me, no.
Okay.
Now,
What?
Okay, I am understand from the ARP to the combination. We wait 24 hours, so we're supposed to take the next dose as your example. If the patient take it at 8 a.m. at the morning, the next dose was, for example, patient take 8 a.m. and now on Sunday, he will take the 8 a.m. combination therapy on Monday. It is okay. But for the ACE, we wait 36 hours. So it is 8, okay, so it is taken 8 a.m. at the morning. Second dose will be on Monday 8 a.m. It is 24 hours. So it's less than 36 hours. So I give it in the same time or wait till the 36 hours. That's
we
what
said. We
do.
said 8 p.m. not a.m. He will take it at 8 p.m.
p.m. So it is okay. So to be past 36 hours. You mean that? Okay.
Yeah. NYHA Quebec, can you open the mic, please?
Yes. I don't understand how to switch from ACE to ARB. I missed the point.
Okay. So I am a congestive heart failure patient, and I take enalapril today. I took enalapril today at 8 a.m. Okay.
Okay.
And my doctor decided to switch me to the ARNI, the combination therapy between sacubitril and valsartan.
Okay.
When should I take it?
Yeah, I missed this point.
Okay.
36 hours.
Yes. So if I took a dose today at 8 a.m., tomorrow, Saturday at 8 a.m., how many hours are done now?
24.
Okay. When I reach 8 p.m. tomorrow, Saturday, how many hours now?
Need 8 hours extra for the 8, so mean like afternoon.
No, 8 p.m. is extra 12 hours, not extra 8 hours.
Yeah, sorry.
Yeah. So 12 plus 24
8 p.m. So 8
equal 36. So we'll take it at 8 p.m. Okay?
Yeah, okay, thank you.
Okay, thanks. Yeah, yes, NYHA Al-Kholi is now doesn't agree with you now, although I noticed that you both agree on everything together. It's called ARNI, not ARB. Yeah. Angiotensin receptor? Yes. Okay.
You have mentioned that restriction for using ARNI, that could be creatinine clearance less than 30. Can you repeat? Can you just
so we don't use the ARNI if the potassium is more than 5.2. Okay, 5.2 millimole per liter. And if the glomerular filtration rate is less than 30 ml per minute.
Okay, thank you.
Okay, my pleasure. Okay.
Excuse me, I have a question. Is the ARNI considered a combination between ACE and ARB?
Okay, so this is a good question because sacubitril give you the feeling of enalapril, lisinopril,
yes.
Correct?
Yes.
Okay, we were about to talk about that. I will show you something here.
First, I have to restart my
my
computer now, so please talk slowly because I'm gonna restart my computer now.
Okay, the answer to this question will come later, don't worry, okay?
Okay, thank you so much.
So don't worry, it's fine, take your time, the answer will come later. Okay, so now I changed the patient from the ACE or the ARP to the ARNI. However, the patient still has symptoms and left ventricular ejection fraction of less than 40. Now I had to do something. Okay. What is done here depends on the clinician preference, depends on the situation of the patients, depends on many factors. Okay, so I can add digoxin because digoxin has positive inotropic effect. It increases the contractility of the heart. So I can add it in that case. Okay, what else? And I can use the hydralazine isosorbate dinitrate in plaque patients. It shows good positive outcome when adding hydralazine isosorbate dinitrate in plaque patients. Or I can add something called ivabradine. Ivabradine is a kind of medication that decreases the heart rate. So it might be considered if the patient is not showing enough response on the combination therapy that I already gave of ARNI plus beta blocker plus spironolactone. This slide, ignore it for now, because it's about some update about the treatment of heart failure. It wasn't updated yet in CTC, and I don't think that will be updated this year. Some clinical trials are done now to use sodium glucose co-transporter inhibitors like the ganagliflozin and the dabigliflozin, canagliflozin, and this family used in treating diabetes to be used in heart failure patient, as it shows to decrease the mortality rate to a high extent, which is a promising thing, but it's not yet updated on CTC. And it hasn't been already used in all hospitals, so we will ignore it for now. It's not updated yet on CTC AMR, and it's not yet validated with all like agency, like medical agency to be used, so we cannot depend on it by now. However, if it's updated on the CTC before the exam, I will keep you updated. So don't get confused about it. Okay. Okay. I need to talk to you about this slide before we leave it, about the algorithm of treating the heart failure. So I have a patient with heart failure and left ventricular ejection fraction of 40 or less. I give him the ACE or the ARB, because if he develop cough or angioedema with ACE, I will give him ARB. But let's say ACE for now. ACE plus beta blocker. No response, I increase the dose. No response, I add the spironolactone or the eplerenone, depending on the patient, which is the MRA. If he responds well, okay, I will monitor and adjust the therapy based on that. No response, I will now switch from the ACE or ARB to the ARNI. If he is controlled, totally fine. Not controlled, now in that case, I need to add something else. Okay. We said about ivabradine, which help in decreasing the heart rate, we can add it. But can I add it to any patient? Like anyone can take ivabradine? It's something that decreases the heart rate. So can anyone receive a medication to decrease heart rate or not?
No.
Okay. So I need to make sure that before adding the ivabradine, that the heart rate of the patient is 70 or more. So if it's less than 70, I will not give it to him. Okay? If the heart rate is less than 70, I will not give ivabradine to the patient. If the patient has atrial fibrillation or has a pacemaker, I cannot play with the heart rate. I will not give ivabradine. So if the patient has a heart rate of less than 70, if the patient has a pacemaker in the heart, if the patient has atrial fibrillation, I will not give ivabradine. All what I do is just changing him or switching him from ACE or ARB to the ARNI. Okay? Okay, people? This is how it happens. Because like the algorithm in CTC is not that clear, like what I will use before what. So what happens is that if the patient, after I give him the triple therapy, the ACE inhibitor plus beta blocker plus spironolactone, and the patient is not controlled, I will look. Okay, this patient's heart rate is 70 or more. Okay, at that point, I will switch the ACE or ARB to ARNI, and I will add ivabradine. So I can consider it here in this area, because the CTC, it's not clear here. So if the patient heart rate is 70 or more, I will switch from ACE or ARB to ARNI, and I will also add the ivabradine here. Like, sorry. Okay, and if the patient heart rate is less than 70, or the patient has a pacemaker, okay, ma'am, the patient has a pacemaker, or the patient has atrial fibrillation, I will only make the switch from ACE or ARB to ARNI, but I will not add ivabradine. Are we okay until this point? Okay.
Doctor, so you mean that we try to switch it first before adding the ivabradine?
No,
if the
what happens actually is that we do the two steps together. If the patient heart rate is 70 or more, I switch and add ivabradine at the same time. If the heart rate is less than 70, or the patient has a pacemaker or atrial fibrillation, I only make the switch without adding ivabradine. Okay?
Okay, so we omit the beta blocker and switch to ARNI.
No. We only make switch from ACE or ARB, but we keep on beta blocker and the MRA.
Okay, no, it is not my question. Okay, listen to me. We are switch from ACE to ARNI, okay? And when I add the ivabradine, we add it on the beta blocker or omit beta blocker?
No, we don't. This is what I'm saying. We keep using the beta blocker and MRA. All the changes about the ACE inhibitor.
So the patient now on ARNI and spironolactones and beta blocker and ivabradine. I am right? It is a quadricycle.
Yes.
Okay.
Okay. So the patient to whom I added ivabradine and switched him from ACE to ARNI, if the patient still have symptoms and the ejection fraction is now less than 35% or less, it means that the medication is not working. At that point, surgical procedure will be considered, but it's not our scope now. Okay, Hand, we will get back to this question later after we finish here. Okay. So the patient whom I gave ivabradine and switch ACE to ARNI and still showing symptoms or ejection fraction of less than 35, at that point, medications are not working, so we need to consider the surgical procedure. However, the other patient whose heart rate was less than 70 or has a pacemaker or atrial fibrillation, and I switched the ACE to ARNI without adding ivabradine, if he doesn't show enough response, at that point I can add hydralazine or nitrate or surgical procedure. So the addition of these things is not that like not random. It happens according to the situation. If I add the ivabradine, I said, plus the switching here. The hydralazine isosorbate dinitrate, I add it as a last step if the patient who cannot use ivabradine didn't show enough response on the ARNI. At that point, I can add hydralazine and isosorbate dinitrate, and this happens in or preferred in plaque patients. Okay, Shams was saying something about the next. Is this a slide you mean, Shams? Yeah, because it's somehow like it's like confusing for me, so I try to say it in that way. Let me look what's done here. Yeah, I see. Yeah, if the heart rate is more than 70, consider ivabradine. If recent heart failure, okay. We don't have in our references, like in CTC, anything about the very sigwats. So this is out of our scope, at least for now. And this is a point we mentioned. If a plaque patient, consider hydralazine nitrate. And so, okay, I'm sorry. It's somehow confusing, so I will repeat again what I said in here, and I hope it's clear for everyone. If you would like to add it by pen and paper to yourself. So a heart failure patient, I will say it again, please, people, if you would like to write it down because it's not written here. Okay, everyone has a pen and paper? Hello? Hello?
Yes, we are ready.
Okay, so a patient with heart failure and left ventricular ejection fraction of 40 or less, I will start him on ACE or ARB plus beta blocker on a low dose. Then I will see. If no response, I will slowly increase the dose. If no response, I will add MRA. Okay. If after that the patient is controlled, that's totally fine. I need to adjust the therapy and the monitor. Nothing else to do. But if the patient is not showing enough response, I had to do something here. So if the patient heart rate is 70 or more, I will do two things. I will do two things. The first thing is add ivabradine to control heart rate more. The second thing is switch ARB or ACE to ARNI. Okay, but if the patient heart rate is less than 70 or the patient has atrial fibrillation or a pacemaker, I will only make the switch from ACE or ARB to ARNI without adding ivabradine. Okay, for the people whom I added ivabradine, okay, Noha, we will come to that later. For the people to whom we added ivabradine and they made the switch, if after that the ejection fraction is 35% or less, it means that the medication are not working very well, and I will consider surgical. Okay, Valentina. Okay. A patient who has heart failure with left ventricular ejection fraction of 40 or less, I will start him on ACE inhibitor or ARB plus beta blocker on low dose. Then I will start to increase the dose slowly. If no response, I will add the MRA. If the patient is controlled, totally fine. Adjust the dose and monitor the patient. If the patient is not controlled, I will do something here. If the patient is okay and his heart rate is 70 or more, I will do two things. I will add the ivabradine and I will switch the ACE or ARB to ARNI. Okay, this is in case of normal patient who has a heart rate of 70 or more. But if the patient heart rate is less than 70, or the patient has atrial fibrillation, or the patient has pacemaker, I cannot add ivabradine. I cannot play with the heart rate in that case. So in that case, I will only make the switch from ACE or ARB to ARNI without adding ivabradine. Okay, Valentina? Okay. Now, after the switch or the addition I did, I will look. For the people to whom I added ivabradine and made the switch from ACE or ARB to ARNI, if their ejection fraction is still low, like 35 or less, I will consider the surgical procedure then. Okay. On the other hand, the people whom I only did the switch because their heart rate is low, or they have a pacemaker, or they have atrial fibrillation, if they are still showing symptoms and low ejection fraction, in that case, if they are plaque patients, I will add hydralazine nitrate. If they are not, I will consider the surgical procedure. Okay? Okay. Now, yeah.
Can I ask now? Okay, so I gonna consider the resynchronization only if he takes the ivabradine, while if he didn't take ivabradine for any condition like pacemaker or atrial fibrillation or NYHA more than 2, so I will consider hydralazine. Am I right?
If he is black.
Okay, what is if he is not black? And
Surgical procedure.
Okay, thank you so much.
My pleasure.
Doctor, please, I have 2 questions. First of all, you said that if the heart rate is still over 70, we are switch to ARNI and add ivabradine in the same step. Okay? Yeah. Can I do for me, it makes sense that I add ARNI and still the effect of the ARNI, because if I add ARPs now plus Varsatan plus Sequestrel, which is the increase of, okay, I'll wait to see the effect. It is not, I cannot add ivabradine in the same step. If it is okay, I give the body some time to respond for the new medication. If it is okay and the heart rate is still over 70, I can then add ivabradine. But if I do both in the same action, maybe the heart rate, and you know that ivabradine now it is in all the prescriptions and like that. Okay, but if I add both in the same step, maybe leads to decrease the heart rate more pushy, and if the heart rate become below 50, I have to discontinue the ivabradine.
Okay, first let's agree on something, Armia. What makes sense to you personally doesn't have to make sense for others. Okay, I know what you are talking about, like the points you are talking about, but this is not how the algorithm works. Like the people who did the trials and tried the medication tried everything. This is why they put the algorithm at the end like that, to do the 2 steps together. Okay, this is first. The second is, even if you are trying to take it by sense, like logically, if you make the switch to someone from ACE or ARB to ARNI, you need to do the switch first, then wait for some time, and then add ivabradine if there is no enough response, correct?
Yes, sir.
What is the point of this wait, in your opinion? Why we are doing this?
To switch the optimal heart rate from 50 to 60.
What's 50? I'm sorry. Like if the heart rate is less than 70, I will not add ivabradine at all.
Yes.
So okay, so what is 50 and 60? I didn't get it.
Okay, we try to reach the heart rate in general in heart failure patient around 50 to 60, around that figure, the resting heart rate.
Okay.
That is because we add beta blocker from the first, as you said, and as I asked you first.
I'm sorry, I
You
still
understand
cannot
me?
get the
Okay.
question.
Okay. No worries. Skip it for the lecture time because I am get the point. Now, you according to the algorithm, we are switching and adding.
Yes.
I am right? Okay.
If the heart rate is more than 70.
Yes. My second question, we can begin with the triples. I know it is not the algorithm, but in some patients, we can begin with the triple therapy at once.
Yes. And this is honestly what generally happens. Like,
Yes.
as it, you will never find someone, I mean, it's rare to find someone on ACE and beta blocker only. There should be like a diuretic there. This is why most
Yes.
doctors start on the triple therapy together. Yes.
Yes, because against to the algorithm, which we add ACE and beta and titrate the dose and then add mineral. Okay, when I see the patient in real practice, the patient come to me have three cardinal symptoms, which is the fatigue and the dyspnea and peripheral edema. So we have to start the triple therapy at once.
Yeah, I'm telling you, like, this is what generally happens. Like, the doctor start most patients on the triple therapy. They need to get rid of the congestion quickly and to limit the effort on the heart. Most of the doctors will start the patient on a triple therapy.
Yes, thank you.
My pleasure. Okay. So someone was asking about digoxin before we go further. So the addition of digoxin is not like something in the algorithm. Like some doctors will add it. Like if the patient is not responding after adding like the ARNI or whatever, maybe before going to the procedure, he will say, okay, let's try digoxin on that case and see what will happen. So it's not like a permanent or not like a specific step in the algorithm. It's like a last line thing that we might add if everything failed before going to the procedure. Okay? Like here, I added everything to the patient and the patient is still showing symptoms before I go to the surgical procedure. Okay, let's try digoxin and see what will happen. So it's not like a must to be used in every patient who tried everything and it doesn't work. The doctor might say, you know what, no need for the digoxin, we will go for the surgical procedure. So digoxin now is not something favorable at all due to the side effects, and also if the potassium level has changed in the body due to a medication or even due to food, a lot of consequences will happen, and the doctor is trying to avoid that. So the use of digoxin now is so limited unless it's for a patient who has been on it for years now. Okay, I'm not sure who asked the question earlier, but this is the situation of digoxin now. It's not something of interest.
So can I know why the surgery is not preferable option for the Black people?
It's not like that. It's like hydralazine and isosorbate dinitrate, like the direct acting vasodilator, show better response in Black patients other than other ethnic or other races. So the surgery might be considered for a Black patient, but before going to the surgery, the doctor will try hydralazine, isosorbate dinitrate, because surgery generally is a last line. So I will not go to the surgery unless I know that all medications are not working very well for the patient. So only for the Black patient, adding hydralazine and isosorbate dinitrate might help me in avoiding the surgery in those patients. But if hydralazine and isosorbate dinitrate didn't work for them, I will consider the surgery for them.
Okay.
Are you okay with that?
Yes.
Okay.
Doctor, please, my last question. The heart failure patient is come from the first symptoms with hyperkalemia, or the hyperkalemia develop as a result of using the ACE and ARB?
What if you are like ACE and ARB will increase the potassium in your blood, correct?
Yes.
Yeah. The disease itself will not increase potassium in your body,
Yes.
because
Okay.
even if you have high potassium, the accumulation of fluid will dilute the potassium in your body.
Okay.
Okay.
Okay. Thank you.
So the high potassium level will result from the use of medications that increase the potassium in our body.
Okay.
Okay. So now where we are. Okay. This is about the medication itself. So regarding ACE inhibitors that end with PRIL, we need to monitor the blood pressure because it will decrease the blood pressure. It increases the potassium level, so I need to monitor the potassium. Also, I need to monitor the kidney function. And also, I need to monitor the level of lithium in my body if I'm taking ACE inhibitor. Generally here regarding the serum creat, ACE inhibitor might increase the serum creat by up to 30%. And even if we reach to the 30%, we don't have to stop the medication. We can just decrease the dose. But if the serum creat increased in our body by more than 30, now we need to change the medication. We might change it to isoniazid with hydralazine, or something else depending on the doctor choice, the clinician choice, if he is not a Black patient. But this is up to the doctor, and this is not common to happen. To take the serum creat more than 30, this is uncommon to happen in a patient. But serum creat will increase generally, and the doctor, if it's like increased by 5 or 10%, no need to change the dose. But if it started to be alarming increase like 20% or more, the doctor at that time might consider decreasing the dose of ACE. So the rule of ACE inhibitor is that it will cause vasodilation, decreasing the peripheral resistance, also decreasing the cardiac remodeling. And we make the titration. We said we start low and go up slow. We will make titration every 1 to 2 weeks up, in addition to the beta blocker. About the beta blocker, we said that we only use 3 medications that show a positive outcome in decreasing the hospitalization and the mortality, which is bisoprolol, carvedilol, and regarding metoprolol, we need to be specific about it. Metoprolol succinate is the one used because the metoprolol tartrate didn't show any positive outcome regarding the hospitalization and mortality. So we use here metoprolol succinate, which is not available in Canada. So it's only bisoprolol and carvedilol now. While being on beta blocker, you need to control, to monitor the blood pressure and the heart rate. And also we make the titration up every 1 to 2 weeks with ACE. And as we said, we need to avoid the beta blocker in acutely decompensated patients. So it's used on compensated patients. And it shows to decrease the mortality and the morbidity, the beta blocker. Arnie, I think know how you were asking about that. So AR, angiotensin receptor. NI, neprilysin inhibitor. So the cyclopetrel is not like normal ACE inhibitor. No, it's like something like a mediator in our body called neprilysin. So NI, which is a cyclopetrel neprilysin inhibitor, is not ACE, it's neprilysin inhibitor. And this combination, it's a medication now. There is no generic for it. It's a brand. It's considered a new medication. It's called Entresto. And as we said, the combination between valsartan and cyclopetrel increase the bioavailability of valsartan. This is why you found the valsartan strength in this combination is around 51 milligram, and it gives the effect of valsartan 80 milligram, although it's only 51 milligram. And this is because the sacubitril increase its bioavailability, making it more effective. And we said that we switch when ACE or ARB are not effective or not tolerated. The washout period is 36 hours when switching ACE to ARNI due to the risk of angioedema and hypotension. We already discussed that. And if it's ARB, we just give it after 24 hours. Like ACE inhibitor, we need, and ARB, we need to monitor the potassium, the blood pressure, and the creatinine clearance, and lithium if someone is taking like bipolar patients. The mineralocorticoid receptor antagonist, spironolactone and eplerenone, are the most common. Spironolactone sometimes associated with gynecomastia. At that point, we change it to eplerenone, which doesn't have this side effect. Spironolactone shows this side effect because it has anti-androgenic effect. This is why it might be associated with gynecomastia. This family of diuretic decrease the mortality and cardiac remodeling, in addition to its role in decreasing the fluid accumulation. This is why it is the preferred family of diuretic in congestive heart failure. And we need to keep an eye on the potassium level, blood pressure, and the creatinine clearance. Okay, so let's say now that a patient is decompensated. Decompensated means extremely accumulated with fluid. What I can give? Now I need to add another diuretic, like spironolactone alone is not enough. I need to get rid of the current congestion that the patient has right now. And I think Hind was asking this question when loop diuretic is used. Correct, Hind? Was it Hind or someone else? Yes, okay. So I use diuretic in this case, like when asthmatic patient has been taking Symbicort regularly and it's not controlling the symptoms, I can give him Ventolin when needed, just to get rid of the shortness of breath he has right now. The same with the other diuretics. If the patient is severely decompensated, severely accumulated with fluid, I need to give him another diuretic just for some time. So I can consider here the thiazide diuretic or the loop diuretic. I use the thiazide only if the creatinine clearance is more than 50, and it's very effective in that case. But if the creatinine clearance is less than 50, I cannot use the thiazide. So in that case, I can use furosemide, something of the loop diuretic. Okay, and the problem here is, if the patient is taking digoxin only, and this is one of the reasons why digoxin now is avoided, because digoxin is affected by the level of potassium in our body because it works on the potassium channels. So if I'm giving a furosemide might cause what to potassium? Can anyone help me?
Hypokalemic.
Okay, so if a patient is already taking digoxin and I give a patient furosemide, this might lead to hypokalemia, and then the toxicity of digoxin will appear. This is why if a patient is in digoxin, we need to avoid the loop diuretic in that case. Okay, the benefit of the diuretic is just for the congestion, to get rid of the extra fluid. There is no effect on mortality. So it's just a kind of temporary addition to the medication, and then we stop it again later. Okay, so this is regarding adding the diuretics to the patients. I will get back to the diuretic mechanism. As I told you, we will discuss it later from last lecture, how diuretics work on our kidney. So regarding digoxin, it's last resort. It's something that we don't depend on anymore. It's last resort if the patient is not responding to anything. So no benefit. Anyway, So it increased the cardiac output due to the positive inotropic effect. It increased the contractility, the force of contractility of heart. This is how it helps in congestive heart failure. And also digoxin, we will study it in arrhythmia, that it has anti-arrhythmic benefit. So it still can be used for this reason. It has no benefit in mortality, no mortality benefit. However, it decreases the hospitalization. Okay, so it decreases the hospitalization, but it has no benefit in mortality. And for digoxin, no need for titration. The dose of digoxin depends on the age, the weight, the creatinine clearance, the medication, the potassium level in the body. So it's a medication that causes a lot of headache to the clinician. This is why they avoid it. We need to consider a lot of things before adding digoxin. It has side effect at low serum drug concentration. It's well tolerated. However, because it has a narrow therapeutic index, it's associated sometimes with arrhythmia because it slows the AV conduction. So if a patient is already taking a beta blocker and already taking ivabradine, and you are going to add digoxin, this patient might at any point develop AV block. This is why it's avoided now. Okay, it's associated with many headache. No need to use it. Might cause anorexia, nausea, and vomiting. Okay, and if you have a patient who is on digoxin and he came to the pharmacy saying that I start to feel like I don't want to eat anymore, I vomited 3 times yesterday. Once you realize that he is on digoxin, what will you do in that case? A patient, like, I need someone to share with me today. Come on, Amr, can you open the mic?
Yes, I think like refer him to emergency because it might be showing, yes, showing the digoxin toxicity.
Yeah, a patient on digoxin and developing nausea, vomiting, or anorexia, and he came to the pharmacy complaining of something like that. This might be due to the disturbance in his potassium level. Right away, refer him to the hospital. Right away. There is nothing else we can do. Also, the toxicity. Yeah.
I think we discussed a question like that 2
Yes,
days ago,
okay.
and
Yes.
I think we have to check his digoxin level first
No,
because
no.
Mhm.
No. Sorry, Noha, for interrupt you, but that is a discussion between me and you and Dr. Habash about a question, and Dr. Ayman, thank you for this question, because we have a question, and I see it in the exam, by the way. That's a very important one. That is, a patient come to your pharmacy after vomiting for 4 days. And the option that you give, you refer him to emergency or urgency, or check the digoxin level. I am answer it, refer him to the emergency. Dr. Habash not agree with me. He said to me in the WhatsApp group that the patient is coming to you by his leg and asking you for something for the vomiting, or to see medication for his vomiting. Actually, I don't agree. He tries many to change my mind. Okay, I appreciate that, but I still refer him to emergency. Even the patient come to me with his leg, he is still vomiting. So the vomiting is alarming sign for the digoxin toxicity. Even the patient can tolerate this vomiting. This is my point of view, and you can correct me. Hello?
Yeah. Hi,
Yeah.
Noha. You would like to say something? Noha, are you still alive there? Okay. So, which Noha? I'm not sure. There was, I think this is a voice of Noha. One Noha was saying something, then Armia said something. Wasn't it Noha, or was it someone else? I'm not sure. The one who was asking.
Yes, I'm sorry. It's me. I'm just trying to copy paste the question for you because
I'm sorry,
I was going with.
First, we are not allowed to take any question from an exam or even discuss any question from the exam. This is totally prohibited.
No, it's a misbah question. It's not an exam question.
Okay, regardless, I don't prefer sharing any questions or talking about anything like that. And please, this is for everyone. Okay. So regarding the situation now, if a patient comes to the pharmacy with symptoms of digoxin toxicity, he is coming to you, the patient is coming by himself to you and having nausea or vomiting or blurred vision or whatever, and you know that he is taking digoxin, and you noted that he might have changed his furosemide recently, he might has eaten some leafy vegetables recently, so a kind of disruption has happened to his potassium level. What are you going to do? If you are confused between sending him to the emergency or measuring his digoxin level, the question is, do you have something in the pharmacy to measure the digoxin level? Where the digoxin level is measured?
I have to refer him to his physician to make.
Does every doctor has something at the clinic to measure the digoxin level? It's a kind of lab work. So the hospital refers the patient to the hospital. Okay. If it's not like a severe case, they will still like give him something to take the potassium level down or do whatever. Or if the patient has clear toxicity, they will give him the DG bind. Otherwise, the patient will die. So it's not something to wait or to think about, or no. Refer the patient to a hospital right away, please, before you kill him. Okay?
Okay.
Anyone would like to object?
Thank you.
Anyone would like to object? Shams, would you like to object?
That's my opinion from the first. Yeah.
Okay.
Thank you, sir.
Okay, we discussed. That's fine. Okay, so where we were. Okay. Now, this is mostly the lecture of heart failure. However, we need to talk about the diuretics. Okay.
Doctor, I have a question.
Ask me.
Yes, maybe to clarify to all of us, we have mentioned that spironolactone, MRA, have benefit for reducing mortality when using for heart failure. While when we speak about diuretic thiazide and loop diuretics, we have mentioned that it doesn't have a benefit. It's only reducing the edema. So it doesn't
have a benefit on the level of mortality.
Yeah,
regarding the mortality.
Yeah, but I mean, spironolactone is also a diuretic.
No. Okay. When we talk about MRA alone, we said that it decreases the mortality and hospitalization, correct?
Yes.
Hello? But we said at certain point, if the patient is severely decompensated, we need to get rid of the fluids right away. So we add the thiazide or the loop diuretics just to get rid of the fluid. So the thiazide and loop diuretic has no role in mortality, just to get rid of the current situation of decompensation, and that's it. This is why we said it's like salbutamol in asthma patient, to be used for emergency, and that's it. But it doesn't help with the disease itself.
Yeah, doctor, I want to add something here.
Yeah.
Yeah, like most of the drugs, as you mentioned earlier, it's because of the results or the outcomes that have been noticed or observed in the clinical trials. So we're not giving spironolactone for its diuresis. It's a mild diuretic anyways. So it's this is the main cause. Yeah, same as ACE inhibitor as well.
Exactly. Its role is its main role is mostly about the mortality, the benefit we take, like decreasing the mortality, but its diuretic effect, like if you compare it with loop diuretic, of course, loop diuretic is much more effective as to cause diuresis, but this is not what I'm looking for in heart failure patients.
Same as ACE inhibitors, we're not taking it because it decreases blood pressure. It's
no,
the
I don't care about
remodeling
blood
and
pressure.
Everything.
Exactly.
Yeah, exactly. Like, yeah, it surpasses the like the class effect of it. It's just like something different. And this is
Yes.
what has been noticed in the clinical trials.
Yes. We said, like, when we were talking about the first graph or the first diagram of the disease, I use this medication to decrease the remodeling of the tissue of the ventricle.
Exactly.
Okay, Noha, no worries. Thank you for joining us today. Stay safe. So Noha, Vancouver, you are alone now. There is no one to support you.
Okay, no worries.
Okay. So yeah, okay. So this is the sites of action of diuretics. We don't need to go through the mechanism anyway, but just to make it clear, because good day for you, Noha, thank you. Au revoir. So we need it in hypertension, we need it in heart failure, we need it in many things. So just we need to know what is the difference between each family of this diuretics. So I have here the plots and the salts and everything is entering here through first. The first thing is proximal convoluted tubule, the PCT. Okay, and it goes through the thing until the end. Anyway, so the first family, which is a very weak family, and you will not see it like frequently, is the carbonic anhydrase 2 inhibitor, something like acetazolamide. Okay, it works here on the PCT, and it's a very weak family. So what it does briefly, it inhibits the transport of bicarbonate out of the PC2 into the interstitium. Like when I prevent that, when I prevent the transport of the bicarbonate, this will lead to less sodium reabsorption at this side. And so greater sodium will be available to be excreted by urine. And when a sodium is there, it will attract more water. So each molecule of sodium will take a molecule of water to be excreted through the urine. But this is a very weak mechanism. This is why this family of diuretics are not commonly used. Anyway, then things are going like that. Then until we reach here to the lobe of Hanel, you will find the osmotic diuretics, something like mannitol. And I'm not sure if you already took the kidney disease or not, like the acute kidney and the chronic kidney injury or not. Has it been given to you or not?
Not yet.
Not yet.
Okay, we will talk about osmotic diuretics at that part in order not to, like this one is used mainly for that, for acute kidney injury. Anyway, we go through here until we reach to the TAL, the thick ascending limb. And this is where the most common family works, like the loop diuretic. Okay, so what loop diuretics does briefly is that it inhibits the sodium potassium chloride co-transporter, this co-transporter here in this area in the thick ascending limb. And this transporter, this kind of transporter that the loop diuretic inhibit is responsible about 25% of sodium load. So when I inhibit this co-transporter, it means that I leave more sodium to get outside the body through the urine, and the sodium will take more water with it. This is why, for example, loop diuretic is much more effective than carbonic anhydrase inhibitor. Okay, someone say something. No, Hind, you said no about what? Sorry. No what? Hind, you wrote no. Is it something related to what we are saying right now or something else? Oh, sorry. Okay. Okay. I'm sorry. So this is where loop diuretics go. Then we go through the DCT, the distal convoluted tubule, until we reach here to the thiazides. And this is the most commonly used thiazide, like hydrochlorothiazide, indapamide, this family. So what thiazide does here is that it inhibits the sodium chloride transporter here, okay? So by inhibiting that, I make more sodium available to get excreted, and it will take more water with it. So we will get rid of water until we reach to the collecting duct. Okay. So once we reach to the collecting duct, we will find here the potassium sparing diuretic. Can anyone give me an example of potassium sparing diuretic?
Spironolactone.
Thank you. The one we were just talking about right now. Okay, so it's called potassium sparing. All what it does, it keeps the potassium in order not to decrease the potassium level in our body and leave the other minerals or the other ions like sodium, chloride to be excreted outside. Okay, so this is how briefly the diuretics work. Sorry. This is how the diuretics work, and a family like that is very weak diuretic. A family like that is very weak diuretic. This, the loop and the thiazide, are the most effective diuretic. But to select which one to use will depend on the creatinine clearance. Can anyone remind me when I use thiazide and when I use loop diuretic depending on the creatinine clearance? Please, thank you.
Yeah, below 50 and above 50.
What is below? Yeah, yes,
above 50,
this is 50 is
both,
like the borderline. Yeah.
Yeah, below 50, you do not use thiazides because they are not like that effective. Above 50, we use furosemide or loop diuretics.
Okay. Yes, exactly. So this is regarding this diuretic. Trying to see if we missed anything here. Okay, I don't think so. So anyone would like to ask something? Because I need to repeat the answer for your question, Ahmed, about afferent and efferent while we keep recording, as it might be said last lecture in a confusing way. So I need to make sure that it's recorded now so anyone can hear it.
Just I have a question about the new guidelines, the use of SLG2. What did you say? Because my computer shut down in that time, so I didn't hear. What did you say?
What I said is that the canagliflozin, dapagliflozin, and this family were found to decrease the mortality to almost 25 to 27% in heart failure patient. This is why there is a trend right now that it might be used with people who has diabetes and heart failure, and at the same time they are thinking about using it for the people who don't even has diabetes, only heart failure, due to its mortality benefit. However, there is like this trend or this thing hasn't been applied in all places yet, so we cannot depend on that unless it's updated on in our CTC, like our main reference of studying.
Okay, thank you so much.
Okay, thank you, doctor. Is it used in first line with the ACE and beta blocker?
Yeah, it's like a quadruple therapy now. They use the ACE plus the beta blocker plus the MRA plus dapagliflozin. Dapagliflozin is the most commonly studied one of this family. But don't get confused. If you need it in the exam, we will update it before the exam if it's added to the CTC. If it's not added, so you don't need it. Anyone would like to? Yeah.
Doctor, I have a question, and sorry, just to confirm something. The accumulation of the fluid in the body for heart failure, it is because the congestion of the right atrium, and therefore the pulmonary V cannot reach it because it is the congestion, so the CO2 accumulates in the body and the fluid. I am right for this understanding?
Yeah.
Okay. Okay. What made me confused? Why the fluid? It is the CO2 accumulated. I am right, but why the fluid?
It is okay. It is a fluid carrying CO2. It is a blood. It is a blood carrying CO2.
Yes.
So
yeah.
You have high level now of fluid and CO2.
Okay.
Why you separate things? Like the fluid carry a gas. The gas might be oxygen or CO2. Now it's the fluid carrying CO2.
Thank you. It is not a relevant point, but just for understanding. Okay.
Okay. I think Hind asked a question here. Okay, Hind. So potassium sparing diuretic are all MRL. This is a very nice question. Can you open the mic, Hind, please? You don't share with us. You don't contribute with us a lot.
Yes, hi.
Hi, how are you?
Yeah, good, thank you.
Okay, so when we talk about the potassium sparing diuretic, we can divide them to two families. Okay?
Okay.
The first family is called the epithelium sodium channel blocker. So it only works on the sodium channel, and it has two members, amiloride and teriametrin. Okay?
Okay.
Amiloride and teriametrin are not mineralocorticoid receptor antagonists. But the other family is the aldosterone antagonist or the mineralocorticoid receptor antagonist. And this one has four members. Two that we know, which is spironolactone and eplerenone, and another two that are not common or not famous, which is the phenyrenone, which is like eplerenone, and the other one is canirenone. Okay? So forget about phenyrenone and canirenone. So we can say that spironolactone and eplerenone are the MRA of the potassium sparing diuretic. However, amiloride and teriametrin are not MRA of the potassium sparing diuretic. So the question now is, can I use teriametrin instead of spironolactone in congestive heart failure?
In heart failure? No.
No, because I need something with aldosterone antagonism effect.
Yeah.
Okay, so I cannot use it. So I can only use spironolactone or eplerenone.
Okay, perfect. Thank you.
My pleasure. Anyone has any other question? So it seems no. Okay, what we are going to do now, because the cardiovascular is a very big chapter, so we are still having arrhythmia in this chapter. It's only arrhythmia now that is missing CHAMS, correct? Yep. Okay, so I would like to give you arrhythmia during the coming week before we reach to Friday in order not to be severely behind. So I will try to prepare the arrhythmia and find a spot during the next week to give it before reaching to Friday. So on Friday we can give the endocrinology, diabetes, hypo and hyperthyroidism. So I need to mention something about arrhythmia. When we talk about arrhythmia, it's mainly about atrial fibrillation, ventricular tachycardia, and supraventricular tachycardia. What we see, or like what we need to focus on, which is most common, which we need, is the atrial fibrillation. However, regarding the ventricular and supraventricular tachycardia, you will not see it that much, and you will not need it much in your exam. So my question to you is, would you like me to focus more on atrial fibrillation and go quickly through the other two topics, ventricular and supraventricular tachycardia, or take everything in details? Quick.
Doctor, the voice, it is, I don't hear you, because, but what I understand, you're asking about the topics. Okay, we can discuss which is relevant to the exam more.
Okay, but you have to agree, everyone has to agree on that.
Okay, yeah.
You know, I agree with you with that, but I see Mo, for example, would like to take everything in details. Why, Mo, why? Noah is asking you why.
I think the exam is, yeah, from friends' experience, the exam is it has a very wide scope, so it always helps to take everything. You never know.
Okay.
That's my opinion. If they don't want, it's okay. But for my part, I'd like to even have the opportunity to take a look at everything. Okay. If everybody's is already agreed on that, let's skip it.
Okay. Mo, let me tell you something. Okay. And what I meant by what I suggested. Okay. Me personally, when I come to discuss a topic, I give more details than what you need in the exam. Like, for example, when we talk today about like how the heart work and receiving and giving the blood and how the congestion happen and what, you don't need that in the exam, okay? You need to know the medication and why the medication is used and the side effect. This is about the exam, okay? But me personally, I tend to go deeper in each topic. I find it easier this way to be clear for everyone. When you know the causes, when you know the roots of anything, it will be clear for you to figure out what's happening later, rather than memorizing the information without knowing why it's happening like that. And when I say about the ventricular and supraventricular, I will not go in details. This doesn't mean that I will not say it in a satisfying way for the exam or for your general understanding. I'm just saying that I will not go deeper or digging deep like what I do in other topics. Okay, you know what I mean?
Fine.
So we will stay cover it, but without like deep why, what, because anyway, atrial fibrillation, we have to go deeper in it to understand it more, but having an understanding of atrial fibrillation, like causes and how it happens, will help you to understand, even without me telling you, the issue with the ventricular and supraventricular tachycardia. So we will still discuss it, but might be not in detailed way like other things. Okay?
Okay, I appreciate that.
Okay. Okay. So anyone has any other question, any comment, any bad word to tell me? I'm all ears now.
Well, thank you.
Okay, I will see you
Just
someday
before
during
we
the week. Once I yeah.
Before we go, doctor, if you don't mind, just to remind our students or dear students, we have made a poll or survey about this course, about the MCQ course, and we would really, really appreciate if you could just fill the survey. It wouldn't take a lot of time from you. I have just posted it here in the chat box, so please consider just filling the survey. It wouldn't take more than 10 minutes, but it would mean a lot to us, and it would mean a lot for you as well, because we're gonna, tweak and change the way that we give our lectures according to your voting. So thank you so much.
على فكرة انت لازم تشتغلي مذيعة.
Yeah,
Dr.
I agree.
Ayman,
I deeply agree.
Dr. Ayman, please, if you put a lecture in the week after your excuse and the excuse of Shams and my colleague, please don't put it on Sundays, because for two reasons. On Sundays at the evening we have a lecture with Dr. Ghazouli, and also on Sunday